Welcome to the Real GI Doc Show. I'm your host, Dr. Fred Gandolfo, and I'm a board-certified gastroenterologist with a medical practice in New York. Today's episode of the show will cover a listener question about a condition called a tortuous colon. This is a very common situation that can cause chronic, lifelong constipation issues that are very difficult to treat, and it is so common and we understand so little about it that it's very frustrating to treat as a gastroenterologist, and I can only imagine how frustrating it must be to be a patient with this condition with little known about it, unfortunately. So let's first talk about a tortuous colon. What does it mean? And then we'll listen to the listener question, and then we'll talk about what to do about it. So a tortuous colon is marked by repeated twists, bends, or turns. And the term tortuous means winding. It doesn't mean torturous, like you're being tortured. It means like a winding road. And this is also called a redundant colon or a loopy colon or a colon that's extra long or has kinks in it. And people have been told all these different things. And the medical term for this is dolichocolon. And I've never heard this term before. I had to look this up. So God knows where this came from. Actually, I do know where it came from. It came from a guy who wrote a paper on this in 1914. And the Greek term for long apparently is dolicho, and colon is colon. We know that. So it's a dolichocolon. So I can't wait to use that in clinical practice. So let's listen to the question by our listener, Elizabeth, and then we'll do our best to, or I'll do my best to answer the question.
Hello, my name is Elizabeth. I am a 60-year-old female, and I am low body mass index. I have a long history. Well, I have what they call many different terms. The infamous tortuous colon, redundant colon, twisty colon, loopy colon. The warm and fuzzy term, though, is the tortuous colon. And that is the one that I have the question in hand. Is there something like, how worried should all the folks that have this be? I do see that it is a finding, and especially with women, I guess, that have a little more colon. So I love your podcast and all your instructional videos. I just, I deal with constipation, have for many, many years. And I'm just trying to understand if there's anything that can be done, any kind of prevention or what have you. Hoping to hear back, and thanks again for your podcasts. Thank you.
Okay. So thank you, Elizabeth, for the thoughtful commentary and the interesting question. I'm glad you like the show, and I'm glad that your people are listening and getting something out of it. So that's very nice to hear as well. So we went into what a tortuous colon is briefly. And before I give any further information, of course, this is just a medical podcast about interesting topics. It's not real patient advice. I'm not talking to you. I'm just talking about general science for a general audience. So don't take what I have to say as medical advice. It's just interesting facts from your friendly neighborhood gastroenterologist. So we talked about what a tortuous colon is. What is a normal colon, first of all? And how do you figure this out? I mean, you can't just measure your colon. And it turns out that there are people out there who do measure colons. And if there's something to be studied, someone studied it probably at some point. So they did an autopsy study in 2015, and that tried to determine the average length of a colon. So they took these 35 cadavers, that people who were in their 80s, I guess they donated their body to science in some way or another, and they measured their colons. They figured out a standard way to measure the colon. And the long story short is they found the average length of the colon is about 51 inches, and plus or minus about 5 inches or so, which makes the colon about 4.5 feet or so, give or take. On average. So that's how long the colon actually is when you look at it anatomically after someone has passed on. And people think that maybe it's a little longer than that. There's other studies that show maybe it's possibly longer, up to 5.5 feet. They noticed that when they measure cadaver colons, it might not be the most accurate because there's some shrinkage involved, as you know. And they've tried to measure colons with radiology, with CAT scans, with surgical procedures, and they come to this range of somewhere in the 4.5 to 5.5 foot range. But the interesting thing about the size or the length of the colon is that men and women have about the same size colon in terms of length on average, and it doesn't actually matter with respect to your height, which I thought was interesting. I mean, I guess it's hard to study this if they're only studying a few people here and there. You need to really see extremes of height to see a difference. But I always figured that the colon, like many other organs, is based more on your height than your body weight, because your weight can change and your organs don't necessarily change. Like your kidneys don't necessarily get bigger or smaller when you gain weight, but nor should the colon or the other major organs. But you would think with height, because your entire body structure is bigger, that you have a bigger colon. But it turns out it's not really true. Kind of cool in terms of these studies, at least. So it didn't really matter if you're a man or a woman, or if you're tall or short. You have roughly a 4.5 to 5.5 foot colon. And the interesting thing was that women are much more likely to have segments of the colon that are hypermobile, that are not attached as tightly to the body as they could be. So especially the ascending colon, which is the right side of the abdomen. The ascending colon is, in women, it can be 62% of women, they say, so 6 out of 10 roughly, will have a mobile ascending colon where it moves around. And why that is, I don't know, but it's interesting that they found that in none of the male specimens in this study. So that may be why we often see redundant colons more in women than in men. And the listener was a thin woman, which is often the hardest person to do a colonoscopy on if you're not looking out for the redundant colon. And luckily, I am looking out for the redundant colon all the time, so we know how to manage that. But it's something that you can't just push the scope through. You have to be very careful, and it's kind of like doing a Rubik's Cube when you're doing these colonoscopies to get around. So I'm going to read a quote about a redundant colon from this paper that I found, and this is from Dr. Dennis Rahav from Copenhagen, and he wrote a paper in 2018 that I'll link below about the redundant colon. A great, interesting page turner. But this is the quote: "The redundant colon represents an unusually lengthened large bowel folded up upon itself, forming extra loops, tortuosities, and kinks. The redundancy may involve the entire colon, or it may be limited to certain areas, as the hepatic flexure, transverse colon, splenic flexure. But the distal colon, especially the region of the sigmoid, is the most commonly affected. There has long been a debate about whether a redundant colon gives rise to symptoms like constipation and volvulus." End quote. And that's the problem. We don't know. Is it a chicken or the egg phenomenon? The redundant colon, if you have one, does it make you constipated? Or are you constipated because you have a redundant colon? And further in the paper, he makes an argument that we'll talk about and answers this question. So that's kind of interesting too. So a redundant colon is when parts of the colon are elongated, they loop around, they enter anatomic spaces they're not supposed to. The sigmoid colon, which is normally supposed to be in your pelvis, comes out of your pelvis superiorly, kind of comes into your abdomen, and the transverse colon, which is supposed to be higher than the sigmoid colon, loops down into the pelvis and kind of crosses over. And when you have this kind of thing, it's called a redundant colon. We don't know the general rate of people who have a redundant colon. In very old studies from the 1930s, they reported the incidence of a redundant colon as low as 2.5%, but also as high as 28%, depending on which study you look at. And I think the problem is that they measure these redundant colons in people that they discover redundant colons in are people who come in for constipation issues. They end up having testing done. And in terms of people coming in for unrelated, just normal CAT scans and things, or I think the study was based on barium enemas, it was only about 2% chance of a random asymptomatic non-constipated person having a redundant colon. But if you look at people with constipation, that number's up there around 20% or so. So it's a very common thing, especially with people with constipation. So we know it's linked to constipation. But again, is it the cause of constipation, or is it the effect of lifelong constipation, the colon stretching out? So here's the thing that was kind of interesting to me, and maybe something I didn't really learn in GI fellowship, which is why you read papers. So colon redundancies are found in newborn infants, and they're thought to be congenital, meaning you're born that way. Symptoms of constipation often start in childhood. People who come in, and I know this from seeing patients, they come in and saying, I have this constipation issue. The people are coming in, they're 60 years old, 70 years old, and they're telling me that they've been constipated since they've been teenagers, as far back as they can remember. And that's not from not eating enough fiber, typically. That's probably because they were born with a redundant colon. They were probably in that 20-ish% range of people who have a redundant colon who suffer from pretty severe constipation. So it's probably congenital. People's colons their length is, the length of your colon apparently is fixed by the time you're 10 years old. You have a full length adult colon. And basically when they're finding these redundant colons in newborns, and even and this unfortunately comes from autopsy studies of newborns and infants, and they find that the colon length is basically, or the colon redundancy is basically a thing that you're born with. So what are the symptoms of a redundant colon? I mean, mainly it's constipation. We talked about that. Elizabeth has this problem, and I see people all day long with long redundant colons who have problems with constipation. Typically, this is like a slow transit constipation. Nothing moves. They have like inertia of the colon, meaning that they just feel bloated and full and gassy and gross, and they don't really get the urge to go to the bathroom. It's not like they're trying to go and they can't get the stool out. It's just that nothing moves. And this is when you hear that someone can't move their bowels for weeks. People come in and they say, I don't move my bowels 2 to 3 weeks, and then I have to take something and I finally empty out, and then I don't go again for 2 or 3 weeks. That's a bad situation, and that's often what you see when you do a study, a CAT scan or whatnot, is you see a redundant colon. You also get lower abdominal pain, distension, and a lot of these vague symptoms of weakness and this brain fog condition that, it wasn't called brain fog a few years ago, but now people are coming in complaining of vague, just not feeling well, feeling sick, kind of feeling foggy and slow thought process and just feeling inflamed. And this is like one of those nebulous things, brain fog. It came up around the time of maybe COVID and all that stuff. But it's a real thing. And it just, it gets, a lot of people use that term. They throw it around like everything else. They hear it on the internet and use it, but it may be a real thing. So here's another quote from this paper. And I thought this was actually the most interesting thing in this paper. And they talked about these vague symptoms that you can get, these non-specific symptoms that you can get with severe constipation. And here is the quote. Non-specific symptoms have also been linked to redundant colon, such as general weakness, headache, and mild fever attacks suggested to be caused by a toxic condition because of fecal stasis. So that means when stool is not really moving through your body or moving through your colon, it's stasis, it's just sitting there. And the quote continues, in the beginning of the 20th century, a theory of auto-intoxication was formulated, but then discredited among little proof of bacterial toxin production. However, immune activation is detected in constipated patients based on levels of CD3, CD4, CD8, and CD25 positive T cells, and by spontaneous proliferation of lymphocytes, T cell activation, elevated levels of antibacterial antibodies, and a tendency towards elevated concentration of IgG, IgM, and circulating immune complexes provide evidence of the stimulation of systemic, cellular, and humoral immunity in chronic constipation. And this is based on a 2005 study. So that's pretty cool. When you get sick and your colon's not moving and it's basically not pushing the waste out of your body and it's sitting there and your body is full of all this stool and bacteria, some of that seems to stimulate the immune system and cause some type of an inflammatory response, and people feel it, and it feels like this brain fog thing. So, and who can't attest that when you have a good BM, when you move the bowels, you just feel better. So imagine walking around your whole life like this. It's not a good situation. What is the typical colon transit time in a normal person? It's about 24 hours. So when food or digested material hits your colon after it gets broken down by your small bowel, when it hits the colon, it should be in the toilet bowl within about 24 hours. When you have a redundant colon, that number of hours can go up to, and this is not like in the severe people who don't go for weeks, but just a general person who has a redundant colon found on an x-ray study who suffers from some constipation, that typical transit time from one side of the colon to the other side of the colon to the toilet can be as long as 52 hours in some studies. So it's like more than twice as much. And that's kind of goes towards more of a general dysmotility of the colon. So it doesn't seem like, and when they study where things are getting held up, it's not that they're getting stuck at these areas where there's like a kink or a bend in the colon. It's that the entire colon just doesn't seem to move. So something to do with being born with a redundant colon must affect the neurologic control of the colon or the muscle control of the colon or the muscle strength or the muscle tone or whatever it is. And basically the colon just doesn't move things along throughout the entire colon. And that's why you get this just slow transit. Stuff just builds up. It just sits there. Colon's more of a bag than it is a muscle that's pushing things out. So what's the treatment? Here's the $1 million question. What is the treatment? And do you treat people with redundant colon any differently than you do just a regular old garden variety constipation? And 100 years ago, this author writes that the treatments for constipation from a redundant colon were enemas, mineral oil, abdominal massage, fiber, water, long walks, naps on the couch, and tranquilizers or sedatives, I guess, just to make you feel okay in the moment. But unfortunately, there's no real guidelines currently in terms of how to manage a redundant colon separately from just how to manage general constipation. There's no current change in the guidelines, and that's a shame. So what do we do in clinical practice? And this author actually mentions that, in the last 100 years, nothing's really changed in how we try to manage constipation. And for as much as we know about so many other things in medicine, treating constipation is about the same. We give laxatives, we do fiber, water, exercise, all those things. What do you do when that doesn't work? When the over-the-counter laxatives and the fiber supplements don't work? And as a side note, I noticed that people with a redundant colon or who have really slow transit constipation, oftentimes fiber is the worst advice. Fiber in food is great. You should get whole foods and all that stuff that we've talked about in the past. But giving fiber supplements especially seems to make things worse. They get gassy, they get bloated, they can't pass it. And universally, almost everybody says that taking Metamucil or other fiber supplements when they have this redundant colon issue makes the symptoms worse. So I often don't advise that as first-line treatment. Sometimes Miralax helps. Sometimes prescription laxatives help, the typical stuff that we give, Linzess, Amitiza, Trulance, all these things that we have as prescriptions are sometimes helpful for people with redundant colons, but it tends to wear off eventually. The medicine works for a week, a month, a few weeks, and then it kind of stops working. The body gets used to it for unclear reasons. But you can cycle through laxatives. You can try one brand and you give them 3 months or so and then it stops working and you try a different brand and get people to go that way, and you just kind of cycle around and the body hopefully doesn't get used to any one thing. You got to keep that colon guessing, but that often works. Prokinetics can sometimes work. There's certain laxatives that help to stimulate the movement of the gut. There's one out currently called Motegrity, which is sometimes useful. It's difficult to get from insurance. It's expensive, but it sometimes is useful because it stimulates the movement of the colon. What you have to try to avoid, unfortunately, and one of the things that does work are stimulant laxatives like Dolichocolon and Senecot. They work in the moment, but the problem is it tends to worsen the problem over time. People tend to get dependent on them, and I've seen people who need multiple doses, not just 2 Senecot tabs at nighttime, but 10 or 20, or they're drinking a gallon of Senecot tea or Sena tea, which could be harmful. It can actually harm your liver. It can cause all kinds of other issues, and eventually it's like any other substance that your body gets used to. You build up a tolerance to it. You need more and more to get that same effect, and eventually it just doesn't work anymore. And now your colon muscles are totally burned out. And if it takes you, I've seen people who take 10 Dolichocolon tabs every day to go to the bathroom, and it doesn't do anything. And that's really that's like a burnt out colon. It's not going to respond to anything at that point. It's very challenging how to manage this kind of problem. And the other problem is that people often come in and they've been having issues like this since teenage years, and they've gotten up to this huge amount of laxatives. And I don't know if there's a way to go back at that point. This damage has been going on for years and years and years. So the long story short is that we don't know. We try to treat it like every other every other type of constipation, and it doesn't always work as well. It's a very frustrating situation. A lot of times it's trial and error. You try something, you try diet changes, you try exercise, you try Miralax, you try water. That's not working. You try prescription laxatives, you up the dose, you combine things in a manner that we don't normally have to do, and hopefully that works. Sometimes we check people for bacterial overgrowth, something called SIBO, because maybe that redundant colon is causing lots of stasis and you're getting this bacterial overgrowth. And sometimes if you have the correct type of bacterial overgrowth or the wrong type, depending on which way you look at it, and you produce lots of methane gas in your colon, so you can test this with a breath test. You can do a lactulose breath test where you measure hydrogen levels and methane levels. If the methane levels are very high, sometimes that contributes to the constipation. If you treat someone with antibiotics, there's a combination of antibiotics that we often use to treat this kind of problem, sometimes the colonic motility actually picks up. It doesn't go back to normal. You usually still need a laxative, but it does sometimes get you out of that funk where you're totally bloated, totally constipated, can't go to the bathroom for weeks, feel sick, feel toxic. I've seen that happen several times where you treat someone, first you test them, you find out if they have small intestinal bacterial overgrowth, and it's characterized by increased methanogen organisms, or whatever you want to call them, and you're making lots of methane gas, and you treat that with a combination of antibiotics, and people do improve quite a bit. Now, sometimes it comes back because if the severe constipation just continues, you get that same situation again. But it is a pretty amazing thing when you treat it and someone does feel quite a bit better. So for Elizabeth, if you haven't been tested for bacterial overgrowth, you may want to ask your physician to consider that. Now, what is the role of surgery? If you have too much colon, should we just take some colon out and maybe things will work a little better? There'll be less of a place for things to get stuck. And back in the day, in the early 1900s, they studied this and they found that it was not a great choice. People had all kinds of complications. People died from surgery. But that was surgery in the 1900s when we didn't have normal stuff like sepsis and anesthesia or aseptic technique, I should say. The people had sepsis because they didn't have aseptic technique as well as they do now. We didn't have great anesthesia. We had no idea what was going on with wound healing and all these other things. So surgery was a very risky proposition, but more recently that's been studied in small studies with 30 or so odd patients, and they found that doing what's called a subtotal colectomy, removing part of the colon, in people who are really refractory to every possible other thing that you would do for a redundant colon that we discussed above, a lot of those patients were happy. They reported daily bowel movements. They reported no significant pain. They did not report major issues with diarrhea from having too little colon. So if you take out a lot of the redundant colon and still leave the lower part of the colon where the rectum and the sphincter muscle is, and you keep your continence and some motility, a lot of people do, according to one study at least, they did get better. So that's an extreme measure, but in some people it actually might be the right thing to do, because in some people that redundant colon is really running their life and they can't live a normal life with a bowel that's full like that all the time and nothing works for it. It can dictate your day-to-day life, and it's a miserable condition. So all these things are options, and it's good to find a team that can work with you, and a good GI doctor and a good colorectal surgeon. And you have to be patient and have a lot of capacity for doing trial and error, because a lot of this is trial and error with these kind of situations. Well, that's all I got today about the redundant colon. I hope you enjoyed this little talk. I did enjoy reading about a problem that I see all the time and seeing these nice drawings from this is from 1820, a cool drawing about all these different redundant colons by hand by an old school doctor. This stuff is pretty cool. People studied every little aspect of everything before we knew anything. Like, we didn't know what DNA was, but we knew how to draw a redundant colon. It's pretty neat. Anyway, now we know what dolichocolon is, and maybe have some more things to think about treating it with. Hopefully you enjoyed this show. If you did, please leave us a review on Apple and a comment if you would be so kind, I should say. If you would be so kind to leave us a comment, that'd be great. I would love to read it, and give me some things to talk about on the next show by leaving me another voice message. Like Elizabeth did here, you can leave me a voice message. I'll leave the link below, and you can ask me an interesting question and make me go look something up for you, and maybe I'll learn something too. So that is it until next time. If you miss me, you can see me on social media, Real GI Doc, and you will see this on this episode also on YouTube. So if you want to see what things look like here in the studio, it's coming along. I still have some work to do, but it's coming along here. If you want to see what things look like here in the studio, you can tune into YouTube and check us out there. And by us, I mean me. Again, I don't know why I say us, like we have a big production studio, because it's just me. Anyway, until next time, hopefully you enjoyed, and thanks for listening. Take care.
That's it for this episode of The Real GI Doc Show. Make sure to join Dr. Gandolfo next time to explore another interesting topic in gastrointestinal health. And remember, the views and opinions presented in today's episode are for informational and entertainment purposes only. Nothing discussed in this episode should be considered or used as a substitute for medical advice, diagnosis, or treatment. If you're experiencing a health issue, please consult with a doctor or a medical provider in your area. Thanks again for listening to the show.